Hello, everyone. It is my pleasure to introduce Dr. Katherine Unverferth, who will be presenting today's Grand Rounds. I've known and worked with Katie for the past 5 years since she was a resident and then chief resident in the Women's Life Center. Her career trajectory since that time has been nothing short of remarkable. She's authored scholarly articles, and she's a CME lecturer on reproductive mental health. In a very few short years, Katie has emerged as an expert in maternal mental health, and her work has been suitably recognized with her appointments as co-director of the Women's Life Center and medical director of the UCLA Maternal Mental Health Program. Katie's a talented and devoted clinician, educator, and administrator, and she's really a role model for residents and fellows who want to establish academic careers at UCLA and beyond. So it is my distinct honor to introduce Dr. Katherine Unverferth, who will speak to us about depression in pregnancy. Katie, take it away.
Can everybody hear me? Perfect. Okay, so this lecture was created sort of based on the most common consult question that we get in the women's clinic, which is a patient coming in saying, I've been stable on escitalopram or Lexapro for years and years and years. Can I take it during pregnancy? And so the hope of this talk is that you will feel empowered to help your patients answer those questions if you're a prescriber. And if you're not a prescriber, my hope is that we're also going to talk about sort of the risk for depression in pregnancy, what we know about it, that you'll sort of start that conversation with your patient so that they can be more empowered as well. The other thing I'm going to do is there was a text I received from a colleague asking a question about management of a depressed pregnant woman. I get a lot of texts from colleagues about, what should I do? What medication should I use? And so I'm going to go over that text because while that colleague was very thoughtful in how they were thinking about this patient and what they were planning to do, it was somewhat misguided. And so I hope that you'll sort of understand the core principles of management of depression during pregnancy after this talk. Okay. I have no financial disclosures. So objectives, it's kind of what we already talked about, right? So I want you to become familiar with the risk factors for antenatal depression so that you can estimate risk in your patients, right? I want you to recognize that pregnancy is not a protected time. I think most of you are probably aware of that, but from a mental health perspective, pregnancy is not a time necessarily of euthymia. I want you to understand the guiding principles of the treatment of depressed pregnant women, and I'll sort of go over the different principles that we use to apply to whether or not somebody should take a medication during pregnancy. And then talk about the risks and benefits of common antidepressants during pregnancy. I hope in a way that is approachable so that you can also use it with your patients, okay? I want to clarify that I will use the term woman in this talk, but by that, I mean anyone who was assigned the female sex at birth. So that can include cisgender women, transgender men, and non-binary people who might undergo pregnancy. We definitely need more research on some of those populations, but today I will use the term woman, okay? All right, so background. So prevalence of depression. So over the lifespan, women are twice as likely to experience depression as men. And so when they've done these studies, what it looks like is that men and women sort of track for the same risk of depression until puberty, at which time women's risk increases and remains elevated all throughout the time that hormones are in play. So until menopause, at which point a woman's risk decreases and equals that of men. And so the thought is that there might be a hormonal component to depression in women that increases their risk. And we'll get into that in a little bit more detail. There's also this idea of a reproductive subtype of depression where hormones might actually trigger the depressive episode. During pregnancy specifically, it looks like about 10 to 15% of women will have a depressive episode. So they will meet the criteria for MDD during pregnancy. Those rates are lower in higher income countries, and those rates are higher in lower income countries. So it varies a little bit by the resources available. The women who will experience symptoms of depression and anxiety during pregnancy is much, much higher than that, okay? But about 10 to 15% depression during pregnancy. Moving on to the predictors. So the most important thing I think for you to understand is that pregnancy is not a protected time, okay? There used to be this idea that pregnancy was a time of glowing, the woman was blissful, so happy to be pregnant, you know, it was a time of euthymia. So the idea was that people could taper off of their medications and they would do fine because pregnancy was protected from a mental health perspective. We know that that's not true, and it's especially not true for our patients with a history of depression, okay? We'll get into these two studies, but essentially recurrent depression really increases your risk for depression during pregnancy, okay? So there were two big studies that looked at this with two different study populations, and I'll explain that. The first was by Lee Cohen and group. It was a prospective cohort study, most of them are, and it was 200 women recruited from psychiatric clinics who were pregnant. And so you can understand that women who are in psychiatric clinics are probably different than women who are not in psychiatric clinics, in that it's a more chronically ill population probably. They had 3 months of euthymia, so they had been doing well on their medications up until the time they found out they were pregnant. And then half decided to taper off of medications and half continued on medications, okay? And what they found is that even those who had been doing well for the few months before, those who came off of their medications relapsed at a high rate of 68%, okay? This is a number I use with my patients fairly regularly, is about 2/3 will have a depressive episode if they come off their antidepressant around the time they find out they're pregnant, okay? Those who continued on medications still relapsed at a fairly high rate of 25%. So 1 in 4 who continued on their medications still met diagnostic criteria for a depressive episode during pregnancy. So the take home is just, you know, watch your patients carefully. I think help them understand that pregnancy can bring up a lot of different things, right? And so help them kind of keep an eye on themselves during that time. This is just the same data illustrated. So the top arrow are those who stayed on their medications. They had fewer relapses. The bottom arrow is those who discontinued their medications, and they had more relapses. There was a second study that effectively found the same thing. So this was by Kimberly Yonkers and group. She's an OB-GYN. They recruited women from hospital and community prenatal sites, so different population, right? So those women are probably less chronically ill. And what they found still was that a depressive episode 6 months before pregnancy and a history of greater than or equal to 4 prior depressive episodes were risk factors for depression during pregnancy. So essentially, if you've had recurrent depression, it's likely that you are going to have it during pregnancy. And so we should monitor that carefully and treat appropriately, okay? I think this is also helpful data for OBs, right? OBs sort of serve as the gateway for mental health care during pregnancy. And so this is helpful. You know, people who have recurrent depression are more likely to have depression during pregnancy. They might want to, I know they're very busy, but keeping an eye on these patients a little bit more closely. Okay, so risk factors. So we know that pregnancy is not a protected time, especially for people with a history of depression. So one of the strongest associations is history of psychiatric disorder. So if you have had depression in the past, you're likely to have it during pregnancy. Domestic violence is a risk factor. You know, I think intimate partner violence gets worse during pregnancy, and especially in the postpartum when a third person is added to that dyad. So monitor carefully for that, right? Screen carefully. Life stress, negative life events, COVID, right? COVID is both a life stress and has led to many negative life events for patients. And so we know that rates of depression have really gone up across the board and also during pregnancy. Low socioeconomic status, anxiety during pregnancy. In my clinical experience, it's, you know, the ones who we see have the most anxiety during pregnancy are really those people who like to be in control, right? They want to control their environment, they want to control their body. And in some ways, I think it's not very hard to understand how pregnancy can be experienced as sort of the ultimate loss of control over your body, right? It's changing in ways you can't necessarily predict, you can't necessarily control, and it can bring up many unexpected health complications, like issues you thought had, you know, resolved. I think, you know, you can see how those patients would have trouble. So when I do my initial screening with patients who I get the sense that they want to be in control, I really try to introduce this idea of mindfulness, of accepting what comes. People experience pregnancy very differently. Let's see how it is for you. But if you can not have any expectations, that might make it easier for you, okay? Other people, health anxiety, right? Pregnancy requires repeated doctor's visits. You have to wait for the results of tests. People with health anxiety can get really activated during pregnancy, understandably. And then smaller inconsistent associations are poor social or relationship support, right? It takes a village. younger maternal age, and then unintended pregnancy. And then given the recent overturning of Roe v. Wade, I wanted to dive into unintended pregnancy a little bit more because I think it's important that as psychiatrists or people who work in this field that we understand what the data shows about that, okay? And so unintended pregnancy, especially unwanted pregnancy, is associated with depressive symptoms. And they separate unwanted versus mistimed. So unwanted is somebody who says, I don't want to be pregnant now and I don't want to be pregnant in the future. Whereas someone who's mistimed, it's like, I don't want to be pregnant now, but I could have been okay with it in the future. And so those where they say it's unwanted are at higher risk for depressive symptoms. The biggest study in this area, and there's a book that kind of goes over the details of it if you're interested in this data, is the Turnaway study. And I believe the book is also called the Turnaway study. And it's a 5-year longitudinal study comparing women who received or were denied an abortion in the US. And so the way they did this study was very creative. They basically, this was run out of UCSF. They looked at abortion clinics within 150 miles of UCSF and looked for those with the latest gestational limits. And then what they did is they compared women who presented in the 2 weeks before, who ultimately received an abortion, to the women who presented 3 weeks after, who were denied an abortion. And in that way, what they were trying to control for was kind of the unwanted pregnancy part of it, right? So they're trying to understand what happens to those women. And those populations ended up being very similar. In the past, they were comparing people who got abortions to people who wanted pregnancies, or they were comparing people who had abortions to people who had miscarried. And those are very different situations, right? So what they found is, interestingly, is that both being denied or receiving an abortion, those patients were more likely to self-diagnose with depression in the first year than in later years. They did self-diagnosis because the population they were looking at had trouble accessing care. So they wanted to understand sort of what was going on with that patient population. And so the way they understand that, at least, is that the unwanted pregnancy, the unintended pregnancy, is traumatic for women in some ways. And so once you get there, if you're denied an abortion or receive an abortion, it is a bit more difficult during the time. That being said, when they've looked longitudinally at it, people do well years out. But initially it's more difficult. They analyzed more recent data, and then they did find that those who were denied an abortion had higher anxiety, lower self-esteem, and life satisfaction 1 week later, as we can imagine, right? I think we're about to have a lot more data in this area. The reason this study was important is that it showed that abortion itself didn't lead to detrimental consequences when you compare it to women who carried the pregnancy to term. So this is the big study that they use to say that abortion doesn't cause long-term side effects. It doesn't cause depression when you think about it in the context of where the woman is having an unwanted pregnancy, okay? The other thing is that women with a history of mental health disorders and trauma were more likely to have negative outcomes after receiving or being denied an abortion. So I think the take home is the same. We have to watch our patients carefully. Our patient population would just need to be, I think, thoroughly followed if this is something they go through. And of course, we need a lot more data in this area. Okay. Other risk factors for depression. So there is this idea of a reproductive subtype of depression, and I alluded to it, right? Women have this higher risk while hormones are in play. There's some thought that at different periods of hormonal transitions, women are more prone to depression. And it's not thought that the hormone levels are different. It's thought that the hormone levels are the same between healthy and unhealthy people, or healthy and people with mental health issues. But they have abnormal responses to normal levels of changing hormones. So that's premenstrual dysphoric disorder, right? There aren't different levels of hormones. It's certain people have abnormal responses to normal levels of changing hormones. The same is thought to be for postpartum depression, for depression during pregnancy, perimenopausal depression. There's some interesting data that weaning might be another major hormonal transition for women, right? People who are breastfeeding and stop breastfeeding. And in my practice, I've seen people who were doing well until weaning and then had the onset of a depressive episode. So again, just kind of to keep in mind these different times. Sometimes we'll screen for hormonal changes and ask the patient sort of, you know, how sensitive are you to hormonal shifts? Women sometimes have a sense, and then kind of use that to calculate, you know, the rough risk for depression during pregnancy. Other things. So not only is pregnancy not a protected time, but untreated depression is not benign, right? Untreated depression during pregnancy has negative outcomes. So the ones that have been most commonly replicated are preterm birth, low birth weight, small progestational age, and decreased breastfeeding initiation. There's some really interesting data that shows that women who are depressed experiencing breastfeeding is more painful and that they have less of an oxytocin release. So in some ways, it's much less pleasurable for them, which maybe contributes to why they don't breastfeed as long or as much. The other thing is that untreated depression during pregnancy has child developmental, social, and behavioral problems. And that's really important and not necessarily something I always talk about with patients, but patients are so worried that antidepressants are going to cause these outcomes. Like, if I take an antidepressant, is my child going to have some behavioral problems? But they fail to understand that untreated depression during pregnancy actually can lead to these outcomes. Other things, they found brain structural and functional changes in children, including changes in the between the amygdala and hippocampus, so areas involved in emotion regulation. There was a study that showed that sort of exposure in utero to an inflammatory cytokine environment led to brain functional changes that you could see and replicate 45 years later. So again, not benign, okay? Additionally, women who are depressed are less likely to receive adequate prenatal care and maybe more likely to use substances that adversely affect behaviors, right? Maybe they're smoking a little bit of marijuana to take the edge off, but they're worried about taking an antidepressant. That's where I think psychoeducation really comes in. The other thing I will sometimes talk about with my patients is it's important that we fully treat your depression. And sometimes the way you get them on board is you talk about, what are your behaviors like when you're on a low dose versus an adequate dose, right? If you're barely getting by on fluoxetine 10 milligrams a day, but if you're on 20, you might be exercising. Are you meditating? Are you having a green smoothie? Are you going on walks? Are you making it to all of your prenatal appointments? I think that you can't discount how much those associated behaviors when someone's doing really well also might help the pregnancy, okay? So if that weren't bad enough, additionally, depression during pregnancy is the biggest risk factor for postpartum depression. So if somebody leaves their depression untreated during pregnancy, it's not going to end in the postpartum, right? It looks like about a third of postpartum depression begins during pregnancy. And postpartum depression over and over again has been shown to be associated with infant impairment of cognitive function, behavioral disturbance, poor physical health, insecure attachment, and depression in the offspring. I think you can imagine how a woman who is depressed in the postpartum, it's going to be very hard for her to respond, flexibly, reflectively to an infant who might be crying all the time, right? That takes a lot of energy when somebody's not depressed. So if you can imagine what it's like when somebody's depressed, you can understand how that reciprocal interaction that's required for infant brain development might be very difficult or might be lacking a bit. That being said, it's very important to screen the partners of your patients for depression. If you have somebody who's postpartum depressed, they're very high risk of having a partner who's depressed as well. And there are studies that show that having one non-depressed partner, one euthymic partner, really helps mitigate some of these negative outcomes. So it's important to have one person in the house, who's able to engage. But so in depressed mothers, mother-infant interactions are less affectively positive and less mutually responsive. So summary, 10 to 15% of women will have depression during pregnancy. With a history of depression, pregnancy is not a protected time. Antenatal depression has negative outcomes and is a risk factor for postpartum depression, which has negative outcomes. And I know we've been focusing a lot on the negative outcomes for the pregnancy or for the fetus or for the infant, but you also can't discount what it's like to be depressed for the patient themselves, right? I think it's really important to understand for that patient, what does an untreated depressive episode look like, right? Have they had suicide attempts? Are they able to function at work? Do they get psychotic, right? Because you have to weigh that as well, right? When you're thinking about tapering medications. And so we get to this idea of a risk-risk situation. And what that means is you have to weigh the risk of the untreated depression during pregnancy and to the woman against the risk of taking a medication during pregnancy. And so that's what you're weighing. You're weighing medication versus depression. You're not weighing medication versus no medication because there's no benign situation when you're dealing with depression in pregnancy. Okay, we'll go into that a bit more. Okay, so moving on to decision-making in the perinatal period. So of course, you're going to take a thorough history. I think a lot of times what I'll do is I'll say, why don't you start from the beginning? How was growing up? How was your relationship with your parents? Like when was the first time you had anxiety or depression? Have you experienced any traumas? And there are specific reasons why I want to know all of those things. I think nothing like having complicated relationships with your parents to really bring up complicated feelings about becoming a parent when you're pregnant. So if you notice that somebody has very complicated like psychosocial dynamics, really encouraging them to try to process that ahead of time. You're also looking for time off of medications and seeing how they've done, right? Have they had years off of fluoxetine and done well, or have they never been able to taper it, right? If they've never been able to taper it, it's probably not going to happen during pregnancy. But if they've had long periods of euthymia, that's something you want to weigh, right? Other things, trauma, very important to screen for trauma in this population. Pregnancy itself with the repeated medical visits, the invasive medical visits, sometimes people experience pregnancy as sort of a de-emphasis of them and an emphasis of the fetus, right? That can feel very disempowering. So pregnancy itself can bring up past trauma. Delivery can bring up trauma. Many women experience delivery as traumatic. And then having this beautiful, vulnerable infant can also really bring up trauma, right? Because you think about how vulnerable this baby is and you remember all of the bad things that have happened to you. So again, really important to get somebody trauma work if they haven't had it, if they have a history of trauma, okay? Other things, social situation supports, right? Again, you just wanna help them shore up their social support. And then breastfeeding desires. I think this is always something I screen for. Again, trying to introduce this idea of uncertainty. Let's see how it goes. I think some women are 100% set on breastfeeding exclusively, but don't understand that it requires sleep deprivation, right? Because breastfeeding, you're essentially awake every 3 hours, especially if you're exclusively breastfeeding. And so you want to think about that with them because many of our patients don't do well with sleep deprivation. So you want to kind of brainstorm with them about how we're going to manage that, okay? And try to meet them where they are. So guiding principles. So we talked about this risk. So again, risk of untreated depression during pregnancy versus the risk of the medication. If you are using a medication like what I alluded to, you want to use it at the lowest effective dose. Not only do you want to kind of have them doing as well as possible, but also what you don't want to do is use a medication at a lower dose than is effective, because then you're getting the exposure to the medication and you're getting the exposure to the depression, right? So what you would prefer to do is optimize the medication and put the depression into remission, because that's believed to be the lowest risk when you're using a medication, okay? Other things you'd prefer to optimize a medication rather than use multiple, right? So instead of somebody on Lexapro, gabapentin, and Klonopin PRN, you might try to pare that down to Lexapro only, maybe even increase it if you need to. And then if the gabapentin and clonazepam are for sleep, maybe refer them to cognitive behavioral therapy for insomnia. I think for a lot of people, pregnancy can be very motivating. A lot of times what I'll tell my patients is it doesn't get easier when you're pregnant. So let's try to handle everything we can now. And often they're receptive to that. Yeah, and then the other thing I'll emphasize is that if a patient gets pregnant on a medication, the decision of which medication to use has already been made. So if a patient is doing well on venlafaxine and has been doing well on venlafaxine for a long time, we wouldn't switch it during pregnancy. The reason for that is twofold. If you switch to a new medication, you're increasing the exposure, right? You're exposing them to another antidepressant. And then you're also exposing them to the risk of a relapse of their depression, right? So there's no guarantee that the medication you're switching them to is going to work. So that's not considered to be worth the risk in this field. And of course, the best time to plan medications during pregnancy is before conception. There's a really interesting fact or statistic that 86% of women ages 40 to 44 have given birth, meaning most of your women are going to give birth in their lifetime. And then there's another statistic that half of pregnancies are unplanned. So half of pregnancies are unplanned and most of your patients are going to give birth at some point in their life. And so I think it's important that you be familiar with this information so that you can help guide them during that time. Okay, so let's talk about these three different situations because the treatment for each of them is a little different. So the first is mild antenatal depression. So someone is doing okay, but they meet criteria for depression. In that case, you would probably refer them to cognitive behavioral therapy or interpersonal therapy if it's available, right? Some kind of validated standardized therapy. They just have the most data in depression in pregnancy. Moving on. If it was a first episode, moderate to severe antenatal depression. And what I mean by that is they have never had a depressive episode in their life. They are antidepressant naive. This is a different situation. So in this situation, if you assess and you think they need a medication, you would likely use an SSRI, and most people would probably use Zoloft, okay? Sertraline has a lot of data. It's sort of the favorite of reproductive psychiatrists. So for a first episode, moderate to severe depression in pregnancy with no prior antidepressant exposure, you would probably use Zoloft. What I don't want you to get is the idea that Zoloft is the only antidepressant that you can use during pregnancy, because that's not true. With recurrent moderate to severe antenatal depression, meaning somebody who's been depressed for most of their life, or they're depressed again, they have a long history of trying different medications, or maybe they've only even tried 3, right? They tried Prozac, they tried Lexapro, but venlafaxine worked better. They tapered off of their medications around the time they found out they're pregnant. They're depressed again. What you would want to do is you would want to use their history to inform the medication choice, right? So you would want to put them on something that's going to work. We have enough data on most of the common antidepressants to use them during pregnancy. So in this case, for that patient that I mentioned, you would use venlafaxine, right? You don't want to use a medication that's not going to work. I think sometimes psychiatrists sort of like try to blunt force it into working, right? They're like, oh, maybe Zoloft will work this time. But we want to use what works because we want the depression to go into remission, because depression is not benign, okay? So just thinking about these cases a little bit differently. And then just a quick foray into breastfeeding. But if an antidepressant is used during pregnancy, we don't recommend changing it in the postpartum. Exposure during pregnancy is thought to be about 5 to 10 times higher than in the postpartum. With antidepressants specifically, in breastfeeding, most of their relative infant doses are less than 10%. And that's this kind of rough or this arbitrary cutoff that people use to say something is safe in breastfeeding. So most of them are less than 10% anyway. There was this really lovely review of national and international medical society guidelines, and most recommended encouraging breastfeeding independent of the antidepressant used. And then if you try to switch them for a misguided reason in the postpartum, you're just exposing them to the risk of relapse again at a vulnerable time. Okay, so we would not recommend that. Conception on medication happens. We talked about it. Most of your patients will give birth. Most or half of them will be unplanned pregnancies. And so this is typically, they find out they're pregnant around 5 to 7 weeks gestation, typically. And so you have to decide what you want to do with that patient in the context of their history. If you do decide to taper the medication, you would do it over a few days. They don't need to abruptly stop and throw themselves into withdrawal. And if they become pregnant on a medication, you would probably use it throughout the pregnancy and for breastfeeding. We wouldn't recommend switching. The only time we really switch is if it's not working. I think that's something, right? If the medication is not working, of course, you have to treat what's happening. The only other thing that comes up is that as women progress through their pregnancy, they get bigger, their volume of distribution increases, their metabolic output changes. And so because of that, a lot of times in the 3rd trimester, you have to increase the dose of the medication. And sometimes we'll go above FDA recommended prescribing guidelines, because that's a very specific case where they might need a higher dose to maintain clinical efficacy. Okay. All right. So moving on to what we know about antidepressants during pregnancy. So just a caveat about the studies in this field, placebo-controlled randomized trials in this specific population are unethical, right? Pregnant patients are a vulnerable population to start out with. And then there's this issue that we know that untreated depression has negative outcomes, okay? So it's unethical to compare depressed untreated women to depressed treated women, because we know that depressed untreated has poorer outcomes. So we can't do these studies. So most of our studies come from observational studies or retrospective studies. The other major thing is this idea of confounding by indication. And confounding by indication means the indication for which the medication is used might be causing the negative outcomes, meaning it is very hard to separate the negative outcomes from the depression from the negative outcomes from the antidepressant. So people have to get really creative with their study designs because it can look like antidepressants are causing negative outcomes, but typically it's the depression when it's controlled for appropriately. Okay. So the 4 outcomes that we're going to talk about are teratogenesis, pregnancy outcomes, neonatal outcomes, and neurodevelopmental outcomes. So these are kind of the 4 things that we think about when we're using medications in pregnancy and postpartum. You would also think about breastfeeding, but we've pretty much covered breastfeeding. So something I always tell my patients is that the baseline malformation rate for any pregnancy is 3 to 5%. Some people, I think that when they're going through pregnancy, think it's 0. And so you want them to understand that with any pregnancy, it's 3 to 5%. And so when we say that SSRIs, SNRIs, Wellbutrin are not major teratogens, what we mean is that they don't increase that risk above the baseline risk, okay? The big study in this area is from Krista Hubricks and colleagues. They did propensity matching, which is one of the best ways we have to control for depression. So they use disease equivalents to try to control for depression and control for that confounding factor. And what they found is when the data was adjusted for the diagnosis of depression and depression equivalents, there were no increased risk of cardiac malformations with first trimester exposure to any antidepressant. This is very reassuring. Cardiac malformations are the most common malformation, which is why this specific paper looked at that. But what we can say is the body of literature does not support the idea that SSRIs, SNRIs, or Wellbutrin increase the risk for major congenital malformations, okay? There was also no significant association between the use of paroxetine and right ventricular outflow tract obstruction. You might be aware that like prior studies showed a possible increased risk of a specific type of cardiac malformation with paroxetine. Newer studies have not borne that out. That being said, people are still cautious about using it during pregnancy. And some people probably wouldn't use it for medical legal reasons. I think you can use it on a case-by-case basis with a lot of informed consent, okay? This is just this data illustrated. So we see that all of the confidence intervals cross 1. So no significant associations with major congenital malformations in these medications. Okay, moving on. So that data is reassuring, right? So looking at pregnancy outcomes, women who take SSRIs have similar rates of miscarriages as those who have depression, reassuring. Length of gestation. Antidepressant use in the 2nd and 3rd trimester is associated with shortened gestation, but it's considered to be clinically insignificant. It's only a few days, it's 0.45 weeks. It's not considered clinically significant. I don't think people are convinced that this isn't residual confounding, right? That they just weren't able to fully control for everything, because we know, of course, that depression can shorten gestation as well, okay? And then birth weight, same thing. So antidepressant use is associated with lower birth weight, but it's 74 grams or a few ounces. Again, not considered clinically significant. That's it. The one thing we do talk about is poor neonatal adaptation syndrome. And what this is it's this, we don't really understand what it is, right? There's some thought that it's exposure to serotonin, or is it withdrawal from serotonin, or is it a different neurobiological disturbance altogether? Part of the issue is that most of the scales that they use to diagnose this in infants is based on opiate withdrawal. And obviously opiate withdrawal is different than what's going on here. But what it is, it's typically mild and self-limited. It's again considered to be relatively clinically insignificant, but it is something that we talk about with our patients. It usually resolves within a few hours, a few days, at the longest a few weeks. It occurs in 0 to 30% of neonates is what we say. And the symptoms can be insomnia, changes in muscle tone, agitation, restlessness, poor feeding, rare respiratory distress. But the caveat is that they did a study where they compared someone who took a continuous SSRI versus someone who was continuously depressed during pregnancy and compared those. And there was no increased risk with those who were exposed to the SSRI. So what is going on, right? We don't completely know. And then there used to be this idea that if you avoided exposure in the last few weeks before delivery to the antidepressant, that it might decrease the risk of this, but that's also not true. So there was a study where women were not exposed in the last 2 weeks and they didn't have a lower risk of this poor neonatal adaptation syndrome. So again, something to talk about with your patient, something to mention, but not necessarily a reason to withhold treatment. I also think it's interesting, the patients who tend to have the most trouble grappling with this are those who have had really bad withdrawal themselves in the past, even though this isn't a withdrawal. So it's like that patient who was super sensitive to venlafaxine and it took her years to get off of it. This patient tends to be more worried about this adaptation syndrome, understandably, because they don't want their infant to go through what they went through. And so psychoeducation is helpful. Persistent pulmonary hypertension of the newborn. Essentially, it looks like there might be a small increased absolute risk with persistent pulmonary hypertension of the newborn. Right, PPHN is that residual right to left shunting of blood. It can be fatal in 5 to 10%. So something to mention, the FDA specifically made a comment about it that said, basically at this time, the FDA advises healthcare professionals not to alter their current clinical practice of treating depression during pregnancy because of this small possible absolute risk. So again, we need more data and our data is difficult to analyze, okay? Neurodevelopmental outcomes, very reassuring. So when studies adjusted for confounders, including the diagnosis of depression, there were no consistent associations with maternal antidepressant use and cognition, behavior, IQ, motor development, speech, language, and scholastic outcomes in children. So very reassuring. There used to be a concern that autism was increased with SSRIs. There were these 2 observational studies that came out. But the major issue, again, was this confounding by indication, because maternal psychiatric illness is also associated with autism. And so they did these kind of creative study designs. So in the first, they restricted analyses to mothers who were diagnosed with depression, and then they compared the rates among siblings. And one sibling had been antidepressant exposed and one sibling had not. And they had similar rates of autism between those siblings. The second study looked at women who received an SSRI before pregnancy, but not during pregnancy. So the thought is that you would capture people who might be at higher risk for autism from a genetic perspective or an environmental perspective. And what they found is that women who took SSRIs before pregnancy, when it could not have impacted the fetus, also had higher risk of autism in their offspring. So again, we don't think that SSRIs increase this risk. We think it's the depression. And this is just a summary of that. When antenatal use in autism, while it's associated, when you control for confounders, this association decreases and remains no longer significant, right? So overall, very, very reassuring data, okay? Let's go over some cases. So this is the text I got from a colleague. So I'm seeing a new patient who will be 29 weeks gestation at the time of our appointment. She is on venlafaxine 150 milligrams extended release. I think has been the whole pregnancy and for 10 plus years, and will want to be on sertraline by the time she has the baby, I'm assuming, so she can breastfeed. Okay, so let's break this down. So somebody who's been on venlafaxine for 10 years, right, and has been on it during the pregnancy, it sounds like she might need the venlafaxine, right? I don't know anything else about this patient, but it looks like the venlafaxine might be helpful for her, right? The second thing is that she's been on it for the duration of the pregnancy. We wouldn't recommend switching at this time. I think, again, there's this idea that Zoloft is the only antidepressant that can be used during pregnancy and postpartum. And I think women get suboptimal care because of that assumption, right? You want to treat what's going on. And like we talked about, you know, the antidepressants as a class are okay in breastfeeding, okay? And most international and national society guidelines agree with that. So the text continues. So I would typically start the new SSRI prior to tapering venlafaxine to help with withdrawal, but would rather not have a pregnant woman on 2 antidepressants. And I think what he's saying is he understands this idea of limiting exposures, right? He understands this idea of if you can have somebody on 1 antidepressant, you prefer to have them on 1 antidepressant. If they need to, that's okay. That being said, if you were cross tapering, you can still cross taper in pregnancy, right? You still want, if you were switching for whatever reason because the medication wasn't working, it is okay to cross taper, right? And then it continues. I was also thinking of timing the taper to have her off venlafaxine by 37 weeks, but then starting sertraline right after the baby is born rather than earlier to avoid neonatal withdrawal. And so again, I think it's this misguided idea that the poor neonatal adaptation syndrome is somehow preventable, which it is not. And that if you remove the antidepressant, that it will go away, and that it's a withdrawal phenomenon. And we don't know that that's the case. Okay. So again, you can see how it's very thoughtful, but sort of using the principles a little bit incorrectly. Okay. And so here it just is all of the correct and incorrect assumptions laid out. We've pretty much gone through them already, so I'll move on. Okay, so the second case. So this was a 39-year-old female, married, unemployed, from Sweden. She had past psychiatric history of borderline personality disorder, panic disorder, and depression, with 7 prior suicide attempts of unclear severity, numerous prior medication trials. She said that she had been cured of DBT. It did sound like she had gotten pretty intense, or she had been cured of borderline personality disorder. It did sound like she got very intensive DBT in Sweden because it was available, and it did seem to help her a lot with coping skills. She had had long-term stability on venlafaxine, Abilify, azopiclone, and Klonopin for 10 years. And then she abruptly stopped all of her medications to undergo IVF. It must have been so difficult to go off of those medications abruptly, right? Can you imagine, right? The withdrawal with venlafaxine alone, and then azopiclone and Klonopin, right? Benzos and Z drugs, must have been really difficult. So you can imagine what women are willing to put themselves through because they think it's safer. And this is where I think her having a reproductive psychiatrist might have been really helpful. So what's her risk of relapse, right? It's high, of course. And was stopping all of her medications recommended? No. So what I might have tried to do is pare them down, right? If she could have gotten away with either Klonopin or Lunesta instead of both, I might have tried to do that. You know, if the venlafaxine could have been optimized and she could have used only Klonopin PRN, maybe, right? But this is somebody who's been very chronically ill. She's probably going to continue being chronically ill during pregnancy, okay? She became pregnant on the first round of IVF, and she did okay for about 5 months, it sounds like. But she did have worsening depressive and anxious symptoms with difficulty eating, disrupted sleep, and severe nausea and vomiting. And so I think, again, you can imagine how not sleeping and not eating, right, not gaining weight appropriately for the pregnancy, these are these associated with behaviors with depression and pregnancy that make it so important to treat too. She did not have a psychiatrist because she previously had traveled back to Sweden every 6 months for treatment. And she had worsening suicidal thoughts with plan, presented to the ER at 5 months, and then had a suicidal gesture in the ER where she wrapped a cord around her neck. And she was admitted to the inpatient psychiatric unit. So what medications would you use, right? You would use the history to inform the medications in a patient like this. This is not a first episode depression. This is somebody who's been chronically depressed. You would want to use whatever had worked in the past, okay? Within reason. And so what they did in the inpatient unit is they started her on sertraline, Abilify, quetiapine, and diphenhydramine. And so this is how I understand this medication regimen. I think, right, sertraline, there's this idea that it's the safest, so you should use it even if there's not a history of response to it. Quetiapine or Seroquel is sort of like the sertraline of the antipsychotics, right? It has low placental transfer, it has low levels in breast milk, so people will often use that as the preferred antipsychotic. The diphenhydramine, I assume, is because they didn't want her on a Z drug or a benzo. So they were kind of using an antihistamine to try to see if that would be helpful instead. And then Abilify. So she did okay, right? Everybody has different ways of understanding this. This is just what I would have done, right? I would have used the history to inform it. So she was admitted to the perinatal PHP where I saw her. She continued to have high anxiety and depressive symptoms. She was blunted. She just looked out of it. Since it was the first time meeting her, it was really hard to know what her baseline was, or was the Seroquel making her really blunt? Who knows, right? The dual antipsychotics. But she kept saying that even though she was so blunted, she was saying she was having intolerable anxiety and depression. Like she seemed very dysregulated. She was having a really tough time. So we kind of up titrated the quetiapine. She was only in the PHP for 2 months. We discharged her, and she did relatively well until the California wildfires. When she would smell the smoke, she would feel like she couldn't breathe, and then it would trigger a panic attack for her. We recommended as much postpartum support as possible. She had financial means, so she had a night nurse and a live-in nanny. I think it would have been very difficult for her to do this without that support. And then she stabilized again until 3 days postpartum and had worsening anxiety, intense fear of being alone with the baby, tearfulness, difficulty functioning. So we readmitted her to the PHP, and at that point we switched the sertraline to venlafaxine, and she did better for a while. She's a chronically sick patient, but just giving you an idea of sort of how these patients present, what can happen. Many patients stop their medications when they find out they're pregnant because there's not enough information, both in the community and for patients, right? So just some resources for you. I'll go through these really quickly. I know we're a little short on time. Mothertobaby.org is great. They are patient-friendly medication fact sheets. I print them out and give them to my patients, or I guess I email them to my patients now in my practice, but they're very digestible, and it's by the Organization of Teratology Information Specialists. Reprotox and LactMed are really, if you want to get very granular with the information. Reprotox goes over all of the data that we know for pregnancy with these medications, talks about fertility or reproductive effects, talks about breastfeeding. With Reprotox, I'm mostly focused on the human data and not the animal data. LactMed, I typically use LactMed. It's just for breastfeeding predominantly. It can be really helpful for looking at levels of antidepressants in breastfeeding. So sometimes I'll look at that. I basically check LactMed for levels and then adverse effects, right? And then womensmentalhealth.org, if you're very interested in this field, if you want to kind of stay abreast of the developments in this field, it's run out of Mass Gen. They send out, you can sign up for a weekly email where they send summaries of the important papers that came out that week on reproductive psychiatry. They also have blog posts. They have a weekly case conference. It's sort of a good way to dip your toes into the community. That's it. All right, so moving on to questions. Does anybody have questions here? Great.
Hi.
Oh, it worked for a second.
There.
Oh, there.
Sorry about that. So yeah, that was super interesting. I have a couple of questions, but the first one is, I don't know, you touched bases or you reviewed this at the beginning of the presentation. I was just wondering, across ethno-racial demographics, do you see perinatal depression? The statistics are there any differences in terms of ethno-racial groups?
I'm not sure about racial groups specifically. We know that lower SES definitely increases the risk for perinatal depression. I think that's a great question. I would imagine it's higher in populations that have, right, like Black women are much more likely to die in childbirth and have worse outcomes overall. So I imagine that they have higher risks of depression during pregnancy, but I'm not aware specifically of the data. Yeah. Great. Another question. So I got a question about TMS for these patients. So for treatment-resistant depression during pregnancy, like meaning they failed multiple medication trials, typically we'll use ECT. So ECT has been long considered to be safe during pregnancy. Typically that's for the more treatment-resistant patients. There has been a move toward using TMS in these patients as well. So if they've had partial response to the medication, you could also consider TMS. There are some small observational studies that have looked at that. Great. Another question, can you talk about your clinical and logistical experience for brexanolone for postpartum depression? Have you been able to get insurance coverage? I have not had a patient get brexanolone yet. I know that they're doing it, I believe, out of Harbor. So I think it's becoming more widely available. Brexanolone is an IV infusion. It's something like 60 hours. It's complicated logistically because it requires a monitored bed. Let me start from the beginning. So brexanolone is allopregnanolone, for those of you who are not aware. It's a progesterone metabolite that works at the GABA-A receptor. And it's thought that during pregnancy, estrogen and progesterone go up, 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 and then they drop off really rapidly in the postpartum. And so in a similar way, allopregnanolone mirrors progesterone. So it goes up and then it drops off. And the GABA-A receptor is where benzodiazepines work, it's where alcohol works. And so it's thought that that withdrawal kind of leads to this agitated depression we see in the postpartum. And so there's a new drug called brexanolone that is an analog of allopregnanolone that's given IV for postpartum depression. And it was really exciting, but it is hard to access. So while there are some spaces that are doing it, it's not widely available. I think the more exciting thing is there is a medication called zuranolone that's orally bioavailable. It's an allopregnanolone analog. It's a 2-week dosing regimen, and the company Sage is looking for FDA approval both for depression and for postpartum depression. So hopefully we'll have that within the next few years, and that I think will be much more widely available and accessible than brexanolone is currently. Oh yeah.
Thank you for this talk. Do you have any thoughts about how psychiatrists can respond after the overturning of Roe v. Wade?
It's a really great question, and it's something I have been struggling with myself. I think part of, what I did over the last few weeks was really try to educate myself about what we know about mental health outcomes after abortion or being denied an abortion. And so that's why I wanted to include the data about the turnaway study, because I do feel like it's important that as psychiatrists, we sort of understand and explain that abortion does not have negative mental health outcomes for the women who get it. I don't have a great answer. I'm trying to figure it out myself. It's been a really difficult time, but I think supporting our women as best we can, and then advocating, I think, where it's appropriate, making sure that we educate our peers who might be misinformed about consequences or lack thereof of abortion. Yeah. Other questions?
Thank you so much for this talk. I have a question about the, knowing that there are physiological changes during pregnancy and its, potential effects on the pharmacokinetics, on certain drug metabolism, absorption, whatever it may be. You mentioned in one of your slides that the recommendation is to not change any of the dosages if the patient is already stable. Would there be any rationale on, increasing or lowering a dose? One thing that comes to mind is like lithium, for example.
Right.
If we have a patient who is on adjunctive lithium therapy, would that change anything?
Yeah, so the two medications used during pregnancy where people will sometimes follow levels are lithium and Lamictal. So lithium levels definitely change during pregnancy, but it's not necessarily in the ways you would expect. So it looks like it decreases in the second trimester and then maybe goes up a little bit in the third trimester. So lithium, if somebody's on it during pregnancy, there is a guideline that recommends checking the levels every 3 weeks and then adjusting to maintain it within the blood level that was previously therapeutic for the patient. Not everybody does that. So some people, again, just treat if there becomes symptoms. So they might check levels, but they wouldn't necessarily adjust it if the patient was doing well. The same thing for Lamictal or lamotrigine. So we know that throughout pregnancy, estrogen increases and estrogen induces the clearance of lamotrigine. So lamotrigine levels definitely decrease during pregnancy. Again, since we don't use levels with lamotrigine to guide our dosing in psychiatry, that the levels are only based on epilepsy, I don't personally check levels on lamotrigine during pregnancy, but some psychiatrists would. They would check like a pre-pregnancy level, see where it is, and then they would work to keep that patient at a similar level. Those are really the only two where we would change dosing. With antidepressants, we usually do it when it's clinically significant. If I had a patient who said, last time I was pregnant, I was on 20 milligrams of Lexapro, but then during the third trimester, it got really bad and 30 milligrams was the thing that worked, and they wanted to prophylactically go up, we could. But I don't personally increase it because of possible recurrence of symptoms. Yeah. Other questions? Great. Thanks for coming to the talk. Let me know if you have any questions.